Well, let's get started. Thank you, everybody, for being with us. I always say, when we're doing something in the family of the Medical Society, it's the best way to spend, and I would say this is the best way to spend a Sunday morning in terms of resetting us in the pandemic. It has been such a stressful couple of years. And I hold up the sixth class of the Healthcare Leadership and Management Scholars as the folks who jumped in when the fire was hot. And they did. They literally signed up for this in the throes of the pandemic. They signed up for extra. And I really am proud of the work that we've been able to do. We have done it all virtually, which is a challenge, and has, brought us together in a way that I think is really unique. Yesterday, I made a commitment, and I'll repeat it here, that we will be together at some point. And I think that's exciting. And it actually speaks to the nature of this program, is that while it's a one-year experiential project-based learning cohort, it's friends for life. It's colleagues for life, and it's understanding to make the House of Medicine better. So what we're doing is really creating groups of people who know each other, who understand each other's challenges. And in a really neat way, as we finish, this will be 62 people who've come through this program who have a better understanding of the challenges that their colleagues are up against and can amplify their voice whenever there's an opportunity to speak about a specialty issue that they may have no reason to know anything about, except that their peer presented a project about it, or they heard a challenging conversation around that issue in medicine. So it's really about connectedness and actually being able to magnify our voices together in advocacy for each other. I am really excited today to share these projects. I am always amazed at the innovation, the dedication, the teamwork that goes into these projects. And I think it's just a really important moment for us to get together and do those things. I would also like to just acknowledge the people who are here with us today, who have been faculty members, who are alumni, who have contributed financially to the foundation and therefore helped the Kanoff Institute for Physician Leadership become what it is and continue to support this work. We shared at last week's annual meeting that it actually cost about $10,000 per scholar to run this program. And about half of that money comes from donation. And so I also think it speaks for the scholar. I know I felt that as I went through the first class of other people invested in me. And I wanted to pay back to the Medical Society and to the state of North Carolina the gift that had been given to me, the extra teaching and understanding. And again, I think the most powerful gift, which is this connectedness that comes from being part of healthcare leadership and management. Before we kick off with our first presenters, I just want to share with folks, since nobody had to walk by this sign on the way in for the entry into the Medical Society, I'll just remind everybody that there's this beautiful the History on a Stick sign that sits outside of the Medical Society. And in lieu of reading the mission statement today, I want to read the sign out front. This was actually placed in 1999 upon the 150th anniversary of the North Carolina Medical Society, and it reads, "Founded April 16, 1849, the North Carolina Medical Society has fostered the advancement of medical science to maintain the high ethical standards and to promote all aspects of the profession with the goal of relieving suffering and improving the health and the lives of the citizens of North Carolina." So with that in mind, I'm going to hand it over to Aubrey, who's going to drive today's presentation. She's going to take care of any technical issues. If you, as a guest, are having problems hearing, please put that in the chat. Please communicate with us. And at the end of each presentation, there'll be an opportunity for people to come off mute and ask questions. We want this to be very interactive. So we're really excited to kick off with our first group of presenters today. They will each introduce themselves. So we'll save the time for the conversation after the presentations. Aubrey, I'll hand it over to you.
Thank you very much. And while I get everything loaded, Tina, do you have anything you want to add in before we get started?
No, thank you so much. I'm very much looking forward to today. As I said yesterday, this is one of these moments when I always get goosebumps listening to the scholars in the program. And thank you to everybody who's here today to be part of this. And thank you to Dr. Conways and Dr. Keever, who continues to work so closely and so invested and dedicated to this program. And Aubrey, to you for being my partner in crime here. So thanks, big thanks to all of you.
All right, first up, we have our vaccination station group. So I'm going to pull up their slides and we'll go ahead and get ready for their presentation. Whenever you all are ready, the floor is yours.
Awesome. Thanks, Aubrey. Good morning, everyone. I'm Pete Bird. I'm kicking things off here for Team Vaccination Station. Our team is Dr. Mina Bhatia, anesthesiologist practicing in Chapel Hill, Dr. Eleanor Green, obstetrician gynecologist practicing in the Triad, and myself, healthcare executive in Durham. Our project is a vaccination station, a mobile vaccination for pediatrics in North Carolina. Next slide, please, Aubrey. Today, we'll be presenting our business plan in the following outline. We'll start with our mission and focus, the objectives that we have for the vaccination station. We'll talk about the solution that we're trying to solve or to address, and that's a shortage of primary care providers in North Carolina, and in particular pockets in North Carolina, and a gap in North Carolina's performance on what we'll find out is a pretty tricky measure, a combination 10 vaccination suite for children. We'll talk about how we plan to address this with our solution and how that is positioned in a competitive landscape, if you will. We'll talk about how we plan to implement this solution, what the finances are, and then the challenges and possible solutions to those challenges that we see. On the right, you'll see a picture of us taken a few weeks ago on a field trip that we made to Lillington, North Carolina, as part of this project. Along our journey, we discovered Dr. Joseph Cassiopo, the chair of community and global medicine at Campbell University, and the mobile medical unit that they're fielding, particularly to serve migrant farm workers and that community. We learned a lot along the way, had some fun, and you'll hear more about that as we move forward. Next slide, please. Our mission with the vaccination station is to improve child health in North Carolina by closing key gaps, driven in part and largely by limited access to primary care providers. The focus of the vaccination station is to increase vaccination rates for children under 2 in North Carolina and decrease the racial and ethnic disparities in vaccinated children. On the right, you'll see some imagery there that centers around Blue Ocean. Blue Ocean strategy is a concept and a way of strategic planning and strategic thinking that we've learned about this year in HCLM. Tina, you did a fabulous job with that. It's about creating new space in which to compete, letting go of traditional boundaries in the way one goes about trying to solve a solution. So you'll see some Blue Ocean imagery as we move forward. Next slide, please. The objectives we have for the vaccination station are to deploy one or more medical mobile units to meet unmet medical needs in rural and underserved counties in North Carolina, with a focus, as I said, on pediatric vaccinations in general and the childhood immunization status, combination 10, NCQA measure in particular. As a reminder, the NCQA is an independent nonprofit organization in the United States, the National Committee for Quality Assurance. It provides standards for measuring quality for both health plans and providers. In North Carolina, the Department of Health and Human Services leans heavily on these standards for measuring quality as we move forward with the transformation of our state's Medicaid program. The combination 10 is a challenging NCQA measure. It's the percentage of children who by their second birthday have received all of a combination of 10 vaccines, diphtheria, polio, MMR, et cetera. It's a challenging measure. It requires multiple visits for these children to come see their primary care provider and be vaccinated. So there's a challenge in front of us. Next slide, please, Aubrey. One of those challenges is the primary care gap in North Carolina. This is well documented. A quick visit to the Shep Center will give you everything you wanted to know about the healthcare workforce in North Carolina. On the left, we see the care gap represented by the number of residents in each county across North Carolina relative to the number of primary care providers. Lit up in orange are the counties that have fewer primary care providers, and in red are those that are in most dire need for primary care. If you look just above North Carolina, you see Franklin County, or just above Wake County, you'll see Franklin County. That in this data set is the county in North Carolina with the most residents per primary care physician, with over 6,000 residents per primary care physician. That would result in about 10 primary care physicians in Franklin County. We did some quick searching yesterday and found out that there are 21 churches in Franklinton alone, the largest city in Franklin County. So just one way to think about that gap. On the right, you'll also see similar shortfalls in pediatricians. We see the same pattern in family medicine, others who care for children. So certainly one of the challenges that we are trying to address is the primary care gap that exists across North Carolina. Next slide, please. One of the results of having so few doctors for children in North Carolina is underperformance on a couple of key NCQA measures. On the left is our focus, this combo 10 measure. You'll see in the light blue bars moving from 2016 to 2019, North Carolina's rate has hovered between 30 and 35%. We're below the national average in the United States of 37% by at least a couple of points. And in the box that we've called out, you'll see varying rates across different ethnic and minority groups, with Black children lagging behind at a rate of 26% for the most current measurement year. We see similar data as children age into adolescence, where the pattern is the same. North Carolina lags the nation, and our Black youth are lagging behind the population overall. Next slide, please. Our solution is to deploy a vaccination station that will consist of a fully equipped medical mobile unit, medical and support personnel plus supplies. The unit would be scheduled to park at convenient locations in underserved geographies, whether that's schools, grocery stores, community events, etc. Pediatric patients would be seen on an appointment and walk-in basis. The key elements of the solution are the van, the unit, the personnel, which we think would be MDs, DOs, advanced practitioners, nurse assistants, and then the logistics support, medical supplies, computers on wheels, vehicle supplies, and as Dr. Bhatia will talk about, advertising and outreach, educational info, and vaccination cards, of course. Next slide, please. One of the strategies that we also learned about in HCLM this year is a strategy canvas. And this canvas compares and contrasts our solution to existing solutions that are already trying to solve this particular problem. In our case, it's local health departments and primary care physicians. Our data for the vaccination station is in the thick blue line. Local health departments and primary care physicians were also illustrated. The boxes on the right sort of call out the summary here. In box 1, you'll see that our main advantages of this solution would be proximity to patients. We may offer advantages on cost and quality as well, given that we're really focused on this pediatric combo 10. However, in box 2, we note that we'll have to overcome shortages or challenges with continuity of care, the range of services that we're offering, and building trust with families. Box 3, therefore, the vaccination station will really need to excel on outreach. And now I'll turn it over to Dr. Bhatia, who will discuss implementation finances associated with the vaccination station.
Thanks so much, Peter. At this point, this is a concept with a really great cause and a really great idea. And what I'm going to talk about is how we turn this concept into a reality. And one of the things that we did to help really gain understanding of the challenges of this is meet with Dr. Cacioppo and actually go out to his mobile clinic in Lillington. They were holding a health fair. About 500 or so patrons came through the health fair. And what he did is he brought his van there, parked it. He set up some tents outside that were able to accommodate patients walking in who needed, blood pressure checks or primary care visits. And it was pretty remarkable, actually. When we went there, you see this large van, you see these very nice tents set up. And as soon as you walk in, it looks just like a doctor's office. There are patient rooms, there are patient tables, all the necessary equipment, very modern, very well equipped. He had sterilization processing abilities. He had refrigerators for medications, everything that you could need for a primary care visit. And so we really learned a lot from him and from this visit about how we could actually implement our vaccination station. His fleet includes 2 large vans and 1 smaller vehicle. And they have, like I said, the ability to have 2 different patient rooms and provide areas for education, for follow-up. He complements all of his vans with a tent system so that patients have an area to wait to receive treatment and also an area for education. Next slide, please, Aubrey. So when we think about the challenges that he faced and the challenges that we're going to face, it really comes down to how do we let people know about our service? And so one of the things we wanted to focus on really was outreach. How can we send the message out there to patients' families, specifically parents or guardians, that we exist and that we're safe and that we're reliable? And one of the things we wanted to do was really go out to these communities and touch the different areas in these communities that they're already connected to. If you go back to Peter's example in Franklinton, there are 21 churches in Franklinton, which is just one town and an entire community. So why don't we go to these churches? Why don't we talk to them about what we're doing? They can spread our mission among their congregation and hopefully the word can get out. So this is what we'd really like to do to help increase awareness. We'd like to go out to the rural hospitals, go out to the schools, hold public events similar to the one in Lillington, and really touch upon the churches and the different communities that people have out there. From this, we think we can increase public awareness, and that's how we plan to get our patients. Next slide. So how do we actually do this? Well, what we think will likely occur is, we would have our van set up, likely at a school, maybe at a football game, a health fair, something similar where we can attract a lot of people. And we'd equip our van with not only a pediatrician or family practice provider, but we would also involve our students. There's so many training programs in North Carolina with nursing students and medical students, and this is a really vital opportunity that they would be able to engage in. They could potentially get course credit for this, or they could just volunteer as part of something that they wanted to do in their training. And what we'd like to see happen is, as the patients come, these nursing or medical students would check them in. They would, get a vaccination history from the patients. They would be able to then, look up the patient's data in the North Carolina Immunization Registry. And then they would proceed to do a history and physical exam. That's part of their training. It's an important aspect, and we would allow them to do that, do a history and physical exam, and then come and present the patients to the on-site pediatrician or family practice provider. We fully understand that in these rural communities, a family practice provider is the pediatrician, is the adult doc, is the obstetrician, so that we fully intend to have whatever we are able to get as far as that. So once the patient was then presented, that nursing and medical student, as well as the physician, would undergo, developing a plan of action. Okay, what are we going to do for this patient? What vaccines do they need? How can we help with educating them? They would then proceed to do the education with the family, and then we would administer the vaccine. Now, it's really important to note that, as Peter talked about, the combo 10 is 10 different vaccines. They cannot all be given at once, and it requires serial visits. And so what we'd want to do is make sure that the families understood that. We would give them the vaccine. We would then observe them for about 15 minutes afterwards, which is standard of care, and realize that this is going to serve as essentially a doctor's office. So we would have all of the appropriate safety medications on board. Our providers would have pediatric advanced life support certification. So if anything were to happen, we would be providing the best and safest care for these patients. Now, once the vaccinations have been administered, the nursing and medical student can help update the medical chart of the patient. They can submit the information to the local health department, which speaks to the NC Immunization Registry. That way, everyone in North Carolina can have access to the fact that this patient now has received this immunization. And then we would set up follow-up appointments. We would make sure that the families knew that, our station was going to be parked here 4 weeks from now when they need to get their, second vaccination. And we would also hand out vaccination cards and information for the families so that they could have that. Next slide. So I bet you're wondering how much this is going to cost. Well, we, like I said, talking with Dr. Cacioppo, we learned a lot about his startup costs, and most of them had to do with the fact that the mobile units are hugely expensive. He quoted us about $700,000 for his 40-foot van, which is not an insignificant amount of money. So what we constructed here is a pro forma that assumed that we would partner with Dr. Cacioppo, which is actually something that he did offer us if we wanted to take him up on that. So you'll see most of our operating costs are actually personnel. Once the van is set up and ready to go, it's really about the people that you have on board. So having a pediatrician or a family practice provider, having potentially a physician assistant or advanced practice provider, having a nurse or a driver, all of these things are where the majority of our costs come into play. Remember, I suggested that we use medical students and nursing students, and that would help definitely offset some of this cost. And when you include the supplies and the labor, our total operating cost that we have quoted here is actually a daily cost. So this is how much it costs for us to send the van out for 1 day of clinic, around $2,800. Now, keep in mind, as I mentioned, that we could offset some of those costs with using students. And also, there are going to be a fair number of our patients that we can actually bill for, so that some of this cost would be offset by insurance. Next slide, please. So the actual implementation that we came up with was really partnering with Dr. Cacioppo and accepting his invitation for us to use his van to go out there and add essentially a pediatric arm to his already existing practice. His funding comes from the CARES grant, which is a state assisted grant, and we would also want to see if there was any way that we could latch on to that grant or potentially apply for a similar state supported grant that supports rural and underserved medical facilities. We would need to definitely find a pediatrician or family medicine provider to work with our existing team. And one of the things we sort of noted as we were talking about this is we may actually be helping the existing family practice providers in these rural areas by helping offload some of the patient burden that they must have. Next slide. So with that, I'm going to turn it over to Dr. Green, who's going to talk to you all about how we plan to expand and some of the challenges that we foresee.
Dr. Green, you're
I
muted.
am unmuted now. Thank you. Once implemented, this is our projected expansion. We project that our startup phase would take 4 to 6 months, and we would start off with 1 clinic per week. And our goal would be to immunize at least 10 children per clinic, and that would result in about a little over 500 immunizations per year. And each year we would add clinics and try to increase the number of children immunized. And hopefully by the 3rd year, we would be up to having a total of 4,000 children immunized per year. And at the end of our at the end of our 4th year, we will try to get another van if we're expanding that quickly. Next slide, please. To conduct such a project, such as this one, there will be challenges, and I'll discuss some of the challenges and solutions. Access barriers will exist in our rural counties. Some people may not have a car, and certainly there may not be as well-developed public transportation. We'll try to address this by offering a gas card of at least $50 or a gift credit card that families could give neighbors or friends, other family members to help get them to the sites in their communities for the vaccinations. Another barrier may be funding. Grant-based funding may run out. We could go and apply for our own grants, and we would certainly accept donations also. And one thing we would like to do is to partner with Campbell, which will keep our costs low, but still we would need at some point our own sustainable funding. We could go to the North Carolina Department of Health and Human Services and try to get a grant, since this will address some of the health needs in rural communities in North Carolina. Another potential challenge is the psychosocial climate and public trust. There may be some vaccine hesitancy, so we will have to have a fairly extensive education campaign in which we will address vaccine safety and communicate that to parents to let them know what the truth is about receiving vaccines, and it is safe and something that they would want to have for their children. There may also be some community or cultural distrust of outsiders or people who don't look like them. To address this, we would communicate with and possibly utilize known and trusted community members, organizations, and providers. And if we could get Black outreach agents, or maybe have a Black provider or a Black student on the mobile unit, that may also help to address potential cultural differences and make the clients feel more welcome while they're there. Another challenge is that we're in year 2 of our COVID-19 pandemic. And of course, we've had some PPE supply chain issues. Things seem to be going okay right now, but it certainly could be possible that we may have issues getting PPE. And so we would want to purchase needed PPE in advance in bulk and hopefully get discounted rates. And also the North Carolina Department of Health and Human Services may be able to help ensure that we have an adequate line of PPE, an adequate chain of PPE. Parental hesitation out of fear of multiple vaccines given together is another issue. And again, this would have to go in the education campaign. I know the CDC has some publications stating that fewer shots, same protection. So we would have to accentuate the positive effects of having the shots and getting this protection for the children. And again, we can do incentive payments where the value would be more for the children who get the combo 10. But even though, even if they don't get the combo 10, we would still want the children to get immunized individually, and they would get a little incentive payment, but it wouldn't be as much as if they got the combo 10. Another barrier is lack of awareness of services. So again, we need a strong advertising campaign with special efforts targeted to groups with lower immunization rates. We would do TV and radio ads, put out flyers, utilize social media, and we would want to just put out as much information in advance of the clinics and put it in areas that is frequently targeted by the groups that we hope to come in. We would go to places like the health department, churches, hospitals, community centers, Department of Social Services, and other places. And so we would want to put out positive images about the benefit of being immunized and the safety of the combo 10 vaccine. So while there will be challenges, we do have a plan to address these challenges. And we feel that we have identified an area in North Carolina that, if addressed, will make a difference in the health and well-being of children and communities across the state. Every child, regardless as to where they live, will have access to improved health by receiving a series of timely vaccinations against 10 different pathogens by the age of 2. Partnering with a program already in existence with outreach targeted to rural counties in North Carolina will facilitate our program and will save the state money. Last slide. Thank you.
Amazing presentation. Thank you guys so much. I'm going to lead off with a question, and then I certainly want our audience to feel free, and also fellow scholars, feel free to, this is the first time you're seeing the live production of their project, feel free to ask a question. So I have been quite old-fashioned. I'm telling on myself, I always pride myself in innovation, but I've been very old-fashioned about the idea that the best way to get these metrics met is to have relationships, right? To have children have a primary care physician. Convince me that that's old-fashioned, that the vaccination station is going to complement the idea of children receiving healthcare on an ongoing basis, and maybe why I should, maybe as a local pediatrician or family practice doctor, I should be excited about the vaccination station.
Well, we are certainly not trying to replace the family physician or the pediatrician. This is to address an additional problem, primarily in areas that we don't have the numbers out here that we need. we plan to communicate with the local providers and let them know that the children are getting immunized. And so we think that that will help them, and that they will be glad to know that these children are getting immunized, even though that they can't necessarily get in there to get it done because of the workload or inability to get into the offices.
And I have to look at my own performance and say, if this, I'm in this small rural community, I'm doing the best I can. And this is the reality on the ground of where we are with immunizations. I think people would be open to as many opportunities for help as possible. Anyone else would like to ask a question of our vaccination station team?
I've got a question.
Go for it.
So I appreciate the thought that you put behind scaling up your project and having to start off, just one clinic a week and then upping over time. I love the partnership idea. I'm wondering, at what point do you think you will be at a scale where you are impacting the overall either regional or state metrics that you are identified as the reason why you started this?
Chip, it's Pete. I'll jump in on that one a little bit. Dr. Bhatia, I see you've got comments as well. The first point I would make is that our financial model and the implementation or scale up model is pretty conservative, as you can see. So I've learned that a good business plan, sets expectations that can be met early on to build credibility and build confidence. But I think it would be some years. The mobile unit at Campbell has been out for a couple of years now and is doing an amazing job and is active for a couple of nights a week and serving a couple of communities. So progress on a statewide front, call me conservative, could take some years. Dr. Bhatia, you probably had a more eloquent answer than that.
No, I was going to say virtually the same thing, that we don't expect that we'll move the metric in the first couple of years. It will take just that enough time for people to even really know about us and trust us. And so I don't expect for us to truly sort of move the needle for at least 3 to 5 years.
So in a follow-up to that and kind of leaning on Dr. Keever's first question, did you all consider just being the mobile resource, but actually utilizing local pediatricians and family doctors instead of taking the doctor there, relying on them as a part of your trust building? Did you consider that? And if so, what was the calculus?
We definitely considered the communication aspect and partnership with local providers. One of the things that we sort of wanted to put ourselves apart from is the fact that there are so few local providers in these areas. In Franklin County, I mean, that's 8 providers for the entire county. So one of the things that we were hoping to do is to communicate through them about our service, so that if they needed to offload patients or if they needed their patients to go somewhere else for vaccines, we may be closer than them. Their only provider may be a 30-minute drive, and we may be doing a clinic in that area. And so it would be a lot of communication like that, as far as, and, I think that the bottom line is they're stretched, they are absolutely stretched. And I can't hear enough about the fact that our rural physicians have a lot of work ahead of them. And so we really think that we'd actually be serving them a benefit in the long run.
I would agree with that. And also, because we have a mobile unit, we can be available to vaccinate after hours and on weekends, which most private physicians cannot do because they're doing all they can already during their office hours. So I would see us as being a facilitating agency to help them in getting their work done and not competitive in any way.
I have a quick question. First a comment. This is awesome. You guys did a great job on this. Back in the olden days when we were lobbying for money for vaccines, we made the argument that if you want people vaccinated, you have to go where the people are. And that's just the way it is. You can't ask people with limited resources to get in a car and drive for a half an hour. They probably have to take off work to do it. And if they're not taking off work, it's a weekend or an evening. So as you have already noted, this has the potential to fill a gap. So I love it. Okay, I absolutely love it. My question is on the funding model. Is there a way? And this is based on very limited information, just a talking point from a long time ago. But we used to say that vaccination pays 10 to 1, 15 to 1. Okay, so if you invest $1 in vaccinations successfully, you are stopping $15 of unnecessary health spending, $10 to $15. That's a guess. It's very imperfect. I wouldn't lean on the precision of that. But my question is, if you are going to make a dent in this problem in a local area or with a group of people, is there a way to look downstream to the folks who will benefit financially from that, the folks that are funding health and health services? To get them interested in this. And, because for low-income populations today in North Carolina, we've got a very different financing model than the one we used to have. And it's changed over the course of the last 4 or 5 years. It's morphed now into we've got private health plans who are, and we have our concerns about them pursuing their pecuniary interests, but is there a way to leverage that to educate those plans about the cost benefit analysis of good, effective vaccinations and get them interested in funding that work with a portion of the money they'll save or won't have to spend because the kids in their plan are healthier? Have you thought about that?
Well, data and economics person over here on the team can at least start one answer to that. And Steve Knuckles taught us well about the economics of healthcare. Steve, thank you for joining today. One of the first things I would do, Steve, is look at other more mature Medicaid managed care states and look at where their combo 10 vaccination rates are and look at the downstream spend on other pediatric services that the vaccinations might prevent, and just do some, get the numbers together to start creating the argument for that. Just one thought out of the gate.
I think the other thing is, insurance companies already have incentives or lower premiums for patients who don't smoke, for patients who have sometimes BMI cutoffs. There's a lot of different areas that I think we can parlay this into. A patient should not have to pay as high of a premium who gets the combo 10 than someone who doesn't, and I think that actually argument can go a long way because there's precedent already.
Ashley Rodriguez, you had your hand up.
Thank you. So 2 questions I'll throw in, not necessarily related. First is, did you do any sort of research or thinking about how this mobile unit would be regulated? So is it like a practice? Is it like an EMS service? What sort of regulations are in place for these units? And then the second would be, during your discussions with Campbell, did you hear any comments or feedback about how that mobile unit was received by the community? So how is it received by churches or schools? Thank you.
We visited Lillington for a community health fair. It was very well received. There were hundreds of people there, and they were very happy to come in. Dr. Badia mentioned how very nice the unit looked and how it looked just like a doctor's office, and it was safe appearing and it was clean. So I would say that the community received it extremely well.
And I think he told us that they had currently been partnering with one of the Baptist churches in the area to help spread the word of them. And they also always have a Spanish-speaking individual on the unit, because when they go out to the farms, most of the workers are Spanish-speaking. So they're, addressing some of the issues that we talked about, is, making people feel comfortable on the unit, seeing people that speak like them or look like them.
And Ashley, on the regulatory front, we didn't get that far, but thankfully we know some great lawyers at the Medical Society who can help us with that in phase 2 of this.
Stay tuned for the email. I am so excited. I just want to call out a simple truth here, which is, and it sounds almost like the setup for a joke, but when an obstetrician, an anesthesiologist, and a strategist, walk into healthcare leadership and management, they actually focus on something they're not experts in. And sometimes that is an incredibly powerful way to approach a problem. And I really want to just applaud the curiosity and courage, right? It's much easier to do something. And we know in particular as physicians, we love to be in our wheelhouse, to be in a comfort zone. And I really am just incredibly proud of this work because they started with something that was uncomfortable and not really well known to them and took it to this amazing project. So thank you guys so much.